This conference will now be recorded.
Yes, ma'am.
All right. Okay. Hang on, let me put my camera on.
Hi, I'm Dr. Shaista, one of the. Hi, I'm Dr. Shaista. Am I talking to Clara John?
Yes, doctor. Oh, that's me.
Hello.
Yes, doctor, that's me.
Clara, how can I help? Clara, how can I help you today?
Yeah, doctor, actually, I'm experiencing this sudden breathlessness and I just immediately rushed here. I didn't know what else to do. Hello? 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 Shasta, I'm not able to hear you. Is there a problem?
Are you okay to talk? Ma'am, some signals. Hello. Voice is cracking
Mm,
in between.
is it breaking
Ma'am,
for
voice
everybody
is
else?
cracking in between. Your voice is not audible.
Is it breaking for everybody else? So that I need to look into my connection otherwise.
No, ma'am.
Dr. Shaista, I think your internet is not that great.
Yeah.
Hello.
Yes, ma'am. I think the signals,
Hmm.
the problem with signals.
Hmm. Okay. Can somebody else give it a go in that case? If because if you are not able to perform properly, then there's really no point. Is that okay with you, Dr. Shaista, or would you like to connect to a better, if it's possible for you? Hello. Quickly, guys. Okay. Okay, and now I can't hear her at all. So I think we will move to the next person, shall we? So any other volunteer? Because Dr. Sandhya will do the second one with you, I guess. Ginny, Rahmat, Usha, Aparna, Asha, anybody? Dr. Madhu, Susan, Manikam. Manikam is always with.
Hi.
Yeah, who is this? Dr. Aisha, is it?
Yes, ma'am, Aisha.
All right, great. Okay, you need some time to think about it, or we can start.
Ma'am, I want to see the previous slide, if any previous slide I have.
Yeah, okay. I give you about a minute because
This conference will
Yeah,
now be recorded.
Clara, I'm 30, doctor.
Okay, Clara. I see that you had a normal vaginal delivery a few weeks back. Am I right?
Uh, yeah, actually, doctor, that was about 5 weeks back. Then I had a normal delivery.
Mm-hmm.
And I actually, since today morning, just got out of breath and finding it very difficult to breathe.
I can see that, Clara. You're in a lot of distress now. Can I connect you to oxygen? Is it
Oh,
okay?
yeah, I think, yes, I'm feeling a bit better. Yes, yeah.
Okay, that's
Okay.
nice to know. So, Clara, can you tell me as to why were you started on these medications? You are taking tablet furosemide, propranolol, and enalapril after your delivery. Do you have any idea about it?
Well, yes, doctor, the thing is that I had a test tube baby because
Mm-hmm.
we've been trying for a while to get pregnant, and then I had
Mm-hmm.
a twin pregnancy.
Okay.
Somehow, through the pregnancy, things seemed to be fine, but
Mm-hmm.
my delivery was quite eventful. I bled a
Mm-hmm.
lot. I
I'm so
even
sorry
needed
to know that, Clara.
of blood, and then I was
Mm-hmm.
in quite a bad shape at the time.
Mm-hmm.
My babies were not even with me, and that was very distressing for me. They
Mm-hmm.
told me that I had developed some sort of a heart problem, and
Mm-hmm.
then I was started on these medicines when I started feeling a little better.
Okay, so if you allow me, I would like to go through your notes at the time of your delivery. Is that okay with you?
Absolutely.
Yeah. Have you got your babies back? Are they doing well now?
Yes, both of them lovely little girls.
That's good to know. And congratulations for your babies. And Clara, for how long have you been feeling this breathlessness?
Well, now just today morning, yes.
Mm-hmm. Okay. And since how long have you been started on these medications?
Hmm. Since the time that had this episode at the time of my delivery, and after that, I've been, when I was discharged, I was taking them regularly.
Okay. Clara, a few more details about your pregnancy. Were you ever diagnosed with hypertension in your pregnancy?
No,
Okay. And after the delivery, what did the doctor say you? Why did he start these medications? Because routinely we don't do this. Are you aware of what has?
I was told that I had some heart, developed some sort of heart problem. They had done a
Mm-hmm.
few tests and scans as well for the heart, and I
Okay.
was told that I had that, and I must continue on the medicines, and I was told I'll be fine.
Mm-hmm.
Yeah.
Okay, Clara. So, Clara, any specific allergies you have?
No,
Okay. And did you have any pregnancy events before this?
no, this was my first pregnancy.
Okay. And any specific conditions in your families?
Not that I know of.
Okay. And did you have any other surgeries?
No,
Okay. Can I know your blood group, Clara?
it's A positive.
Okay. So, Clara, I have got the reports, and they say that your blood hemoglobin, it is slightly towards the lower side. Okay. And we will be starting you on iron medication for this. Okay.
Mm-hmm.
And your WBC count, that is your white cells, they are slightly towards the higher side. So we will be giving you antibiotics for that. Okay.
Mm-hmm.
And the echocardiography that has been done, the heart scan which was done for you, it says that it's slightly not working properly. I mean, we call this condition as peripartum cardiomyopathy. So is there someone with you to support you now? Because we need to admit you, Clara, in the hospital now for this condition.
Oh no, but I don't want to be away from my babies again. And I mean, these tests for me were done at the time when I was admitted.
Mhm.
I was better. I was better after that. Is this why am I breathless again now?
There is a possibility, Clara, that your condition is presently not very well controlled on the medications you are taking. So we need to admit you in hospital. It will be a team of doctors, health professionals will be taking care of you. I need to arrange a referral with a cardiologist. My obstetrician who specializes in cardiac diseases will be taking care of you. And uh, I'll also inform the anesthetist and ICU in charge. And we will need to do some more investigations for you presently. Okay. And along with this breathlessness, are you having pain as well?
Oh, yeah, actually, I'm just having this gripping chest pain as well.
Okay. So, because the ECG, it shows that you're having a slightly increased heart rate, and some abnormalities are seen on the ECG as well. So, I'll be arranging a referral with the cardiologist because they will be going in more details about your condition, and
Mm-hmm.
then a team will be deciding about your ongoing care from here. I know this is difficult for you. I'll arrange a counselor for you as well. And I can understand that you are worried about your babies, but presently we need to make sure that you are better. Your condition improves right now. Okay. So we
Mm-hmm.
need to admit you as well, Clara.
Doctor, what investigations, what could this possibly be? Why am I?
There is in this condition, it shows that you are having a peripartum cardiomyopathy. This is a condition, usually it happens after a delivery because there are some women with having a twin delivery and increased bleeding at delivery can put you at risk of this condition. So this could be a probability in your case. And as well as ECG also shows some changes. That is, some problems, abnormalities are there in the ECG. There is a likely possibility that you might be having a condition called as myocardial infarction. So both of these conditions are slightly serious. So we need to admit you and work up further for you.
Hmm.
Okay,
Hmm.
and we will be starting medications and liaison with the cardiologist. So a team of specialist doctors will be taking care of you and
All right.
starting you with the
All right.
treatment.
Let me stop you there. Meanwhile,
Okay.
the examiner provides you with the findings of an assessment done now by you.
Okay. Okay, so Clara, I have confirmed your name and NHS number on the reports. Uh, it shows that your pulse rate is slightly towards the higher side and oxygen is also low. So we will connect you to oxygen now and we'll start you on medications. And it is showing that this condition of peripartum cardiomyopathy. Are you aware of this condition because you were already started on medication? So are you aware of what has happened to you after delivery?
Yeah, I was told I have some heart problem. I don't,
Mm-hmm.
wherein it was pumping very weakly. I was told that, yes.
Yeah. So we have repeated all your tests. It shows that presently you are having a condition called as peripartum cardiomyopathy. And this, what basically happens is the heart is not functioning properly, and because the heart is weak, so you have developed the symptoms of breathlessness, and there are other changes also we can see on your blood reports, like you are having anemia. So we need to correct that anemia as well.
Hmm.
And slightly there is increased in your WBC count, which shows that there could be a possibility of infection. So we will do other tests like urine tests to check the source of this infection, and we'll send some blood cultures as well, and we'll start you on antibiotics for this. And we will arrange a meeting with the cardiologist, so he'll come and see you and start you on the medications that are required for the heart failure. Okay. And
Hmm.
your admission will be done in an ICU to stabilize your condition. And I'll inform my consultant as well. He'll be here to see you, review your case. Okay.
Okay, doctor.
So, what are your thoughts, Clara? What do you think? Would you like to get admitted now?
I could get admitted, but I'm just worried about my babies. I don't know what this means. Why has it worsened, and what is the outlook now? for me?
Yeah, some women with some risk factors like having a twin delivery and having increased blood loss at the delivery can put to risk of such condition. So there could be a possibility that why you have developed this condition. And uh, there are chances that you might have, there is a good improvement once we start treatment. We'll be monitoring your condition, and most of the times this condition improves with time, but there are chances that 1 in 2 women can have the similar condition in the next pregnancy as well. Okay, Clara. And your next pregnancy plan, it also depends upon how much is the problem with the heart, because most of the women, they recover fully after having this episode, but in some women there is a possibility that there is some residual disease which can put you at risk in next pregnancy.
Okay.
Okay, Clara. Is there anything else you would like to know?
No, that is it.
Okay, thank you very much. So I'll make an admission for you, and I'll also inform my consultant to come and have a talk with you.
Okay.
Okay, thank you.
Thank you. Thank you, Dr. Aisha.
Thank you, ma'am.
Yes. Yeah. Alrighty. Can we have Sandhya?
Yes, ma'am.
Sandhya, hi.
Hi.
Okay. Let me show you your task. Again, it's going to be pretty much similar in the write-up, but you have to tell me where it is different. And there you go.
Ma'am, this is the same task.
No, it's not the same task. It's not the same task. Read it carefully. Okay, and the next slide as well. Shall I go to the next slide?
Yes.
Yeah.
Yes, ma'am. Next slide.
Yeah.
Previous slide.
Yes.
Hello, I am Dr. Sandhya, one of the doctor in clinic today. Am I talking to Clara Cooper?
Yeah, that's me, doctor.
Okay. Clara, I can see that you are having difficulty. Do you want, can I attach oxygen, make you propped up and attach oxygen to make you comfortable?
No, I'm just a little bit uncomfortable. That's fine.
So, Clara, can I confirm your age?
I'm 30.
And can I call you Clara?
Yeah, sure.
Clara, I went through your notes and I'm aware of your situation. Is that okay if I just ask few questions from you to understand more about you so that we can formulate a safe, acceptable, mutually agreed plan? How
Please
does
go
it
ahead.
sound to you?
Yes, please go ahead.
Could you tell me more about your condition at present?
Well, actually, doctor, I delivered about 5 weeks ago. That I had twin babies delivered normally as well. I was 37 weeks at the time. But it was quite eventful in terms of how it all happened. I bled a lot. I've received 2 units of blood as well. At the time, my heart had some concerns, the doctor said, because they assessed me. I had the same sort of a breathlessness, but it was much worse at the time. And they admitted me in the ICU. I was there for around 4 days and put on some medications. And then I was quite stable and I was discharged. I started feeling a little uneasy today, and that's why I thought of visiting.
I can see that if you have any complaint of chest pain
No, not at all.
and how are you how are you doing now? Means what about your baby? Do we have a name for the baby?
Yeah, they're called Ginny and Johnny, and they're both doing fine.
If they are breastfeeding?
Yes,
Clara, could you tell me about your pregnancy?
pregnancy was quite smooth. Conceiving was a bit tricky, but after I conceived, I was on regular follow-ups. I wasn't told of any problems.
And all your blood pressure records were normal
Yes, they
during
were.
pregnancy?
Yes,
And this is your first pregnancy, right?
yes, that's true.
Do you have any other medical condition
No,
and any surgery in the past?
no,
Any allergy?
no.
And are you aware of your weight to height ratio?
It's 23.
Do you smoke, take alcohol, or any recreational drugs?
None of that.
And what about your family support?
I'm very well supported, especially at this time. Yes.
And okay, and you are taking good diet, sleeping adequately after means delivery?
Yes, I would say that.
So, okay. Thank you, Clara, for giving all this information. Anything else you want me to know?
No, nothing additional.
Is that okay if I just examine you in the presence of saffron? Midwife will take your pulse, blood pressure, and I will do a general examination. Also examine your heart and tummy examination. Is that okay for you?
That's fine, doctor. Yes, the findings are provided to you.
Yes. Thank you for that. So, Clara, I have your findings and I have confirmed from your name, age, NHS number that these reports belongs to you. Clara, in this report, it is showing that some investigations has been done and your hemoglobin is in slightly lower side and also a, a specialized imaging test of a heart has been done which is in which it is showing that your heart is not functioning properly. Its ejection fraction, that is pumping of the heart, is quite low, which is 50%. And your in the chest x-ray has been done of the chest, which is showing that there is your heart is slightly enlarged in size, which it seems that after seeing all your examination and investigations finding, it
Uh-huh.
seems that you have a condition which we it it at present, Clara, I could not tell about the condition, but it seems that it is likely dilated cardiomyopathy. Are you
Oh.
aware of it?
Yeah. I was told that I had this cardiomyopathy or something weakness. when I was discharged. But I believe that the last time around they told me it was not pumping at all. You tell me it's 50%, so I feel that's improvement, right? Isn't it better?
Yes, at present, the pumping is 50%. But Clara, let me tell you that right now, as you are feeling uncomfortable, so actually I have to take opinion from my consultant, and also your further management will be done by team of doctors, including
Okay.
our consultant, then heart doctor, and anesthetist, and
Okay.
and also a specialist midwife will be included in your management. And you may be offered admission at present because the ejection fraction as the this 50% is also quite low, so you may be the team of doctor may decide that there is a need of admission in your situation, but right now I cannot say for sure. We have to take further opinion, and also further investigations may be needed.
That's all right. I had a few concerns though about, I feel like I'm getting better. So I wanted to try for another pregnancy in the future. So I wanted to know more about that as well.
Actually, yes, Clara, let me tell you that there is a chance of recurrence in the next pregnancy also. And whenever you try for the next pregnancy, then you have to, uh, first of all, you have to take opinion from your cardiac doctor also, and your regular treatment from now also. We will refer you to heart doctor for your further treatment of this condition. And after you will be advised for certain medications. So prior, it will be advisable that prior to pregnancy, you have to be in the optimum of your health, so that you can carry pregnant for a safe pregnancy further. And only it will be advisable when your cardiac doctor and the gynecologist obstetricians give you a green signal regarding the future pregnancy. Till that, it will be advisable for you to take a safe contraception, which will be the progesterone. In heart conditions, we usually advise for progesterone only. Pills are given which containing the progesterone hormone. Am I making myself clear?
Anything further I need to know if I'm planning another pregnancy though?
And in further pregnancy, yes, your regular monitoring will be done, and prior to pregnancy, it will be your heart condition will be assessed, and if after pregnancy also, more frequent visits will be needed, and also the cardiac echocardiogram, that is the heart functioning, will be tested at regular intervals, and you will be put on the medications also. Clara, I will also provide you some information leaflet so that you can go through it. And also, right now, I will, as you are taking the medicines, I will advise you to continue these medicines. These all medicines are baby-friendly medicines, and you can continue the breastfeeding with these medicines. And I will fix sooner. I will fix an appointment with my consultant and also a heart doctor for further. And thank you for your time, Clara. Anything else you want to know?
No, just that what we need to do further in the future pregnancy because I really want to try again.
I will ask from my consultant and give you more information regarding further.
All right. Dr. Sandhya, now I will ask you, is it the same station?
No, no, it's different.
Okay, what is the difference? Let's get to Dr. Ayesha and Dr. Sandhya. Can you spot the differences even in the question itself? What are the differences?
This case is she is a more stable patient and she's coming to a postpartum clinic. So basically, she wants an ongoing care for this patient and next planning for next pregnancy.
Correct.
And the previous case, it
Very
was an
interesting.
emergency case. So immediate
Yes.
treatment was required for that patient. And
Yes.
so first we need to stabilize her condition. And then at the time of discharge, we could have discussed with different options for that patient.
Right. Right. Okay. Also, you will notice there are differences mentioned here. For instance, in the first station, patient is in A&E. Okay.
Yes.
And the way the patient presents also is different. A&E should put you on an alert that this is something else. Okay. So anytime the purpose of the exercise is to bring to your attention that no two stations are the same. Even if they look the same, they will appear the same, they smell the same, they will not be the same. So there may be something completely different. Go always with an open mind. Is that clear? Manikam, as we were doing last time, same lesson.
Yes, ma'am.
Yeah? Okay.
Yes, ma'am.
So the second patient, in fact, had come to the postnatal clinic, which was like a visit. She's having some breathlessness, it's mentioned. But as you talk to the role player, you understand. Okay. Second most important take-home message is listen very carefully. Listen to what they are saying, what they are asking, and reply appropriately. Okay. What it appears on the face may not exactly be what it is or the agenda of the station is. So the first station, let us say if I'm college and I'm testing a candidate based on this station, what am I looking for as an examiner? I am looking at somebody who's able to pick up that this is an emergency, okay, because they are breathless and they are like doing things on an urgent basis. They are offering oxygen and what all needs to be done under the circumstances. All right. If you look here, even the investigations are slightly different. We have provided you with ejection fraction of 35% in this circumstance. So this is in your 2-minute interval, right? So when I'm providing you this particular template, what it means is, and I've specified here, so have that situational awareness, read your question very carefully. Read the question. Don't assume that it is something that you've read somewhere in some book or something has been taught to you in the past, and it's going to be exactly the same. So don't go under that assumption. First, it is provided to you here that she was shifted to ICU post delivery and okay investigated. These are attached overleaf, means these are investigations when she was admitted. You get me, Dr. Aisha?
Yes, ma'am.
Yeah. So these are investigations at the time. Now I have come, and then even as a role player, I was trying to ask you or help you out with, Doctor, why am I breathless? So she's wondering. Basically, I was pointing you towards what are you thinking now? Why am I having breathing difficulty? All right. And one very vital question which you asked me somewhere in the middle was, are you having chest pain?
Yes, ma'am.
Yeah. So then the station takes then you suddenly realize, okay, this is something else. This is not the postnatal station. And then, it's going, okay. So the agenda of that station was take a detailed history. Of course, for PPCM, you need some amount of details in the history. I will come to all of that in a bit, but let's tell you the gist of the first station is take a history in order to see why this woman is having breathlessness now. Okay, so what are your differentials that you're looking at? And then tell the patient, okay, you're breathless, you're right. I'm thinking of a few possibilities. There will not always be one, right? You can't tell me that I'm having myocardial
Yes.
infarction
Yes, ma'am.
only, yeah? So there will be either, it can be just worsening of PPCM, even if there is pulmonary edema, congestion can sometimes present with, a feeling of tightness that she's feeling that pain sort of sensation. That is one of the things. There can be an MI, yeah. There can be an embolism, cannot be. LVEF was 35% patient, wasn't even, we don't know if the patient, because you haven't asked. you don't know if the patient was on blood thinner or not. Yeah.
Yes, ma'am.
And she could have developed an intracardiac clot, which could have embolized, possible. So she's come with chest pain and breathlessness. So you're thinking all these things. Keep your mind open at that point of time. What are the possibilities? Why she's come postnatally with this particular complaint? Tell her, okay, I feel that these are the possibilities. Let us look into that. What I need to do is examine you very quickly and look at your stats, pulse, blood pressure as well, and we will do a few quick investigations because I feel that it can be a clot, it can be the, that, uh, as you said, infarction, that is, if the, what we call as a heart attack could be there, which
Yes,
it's not getting enough blood supply, so that's developed. Or it could be the condition that you are having already is worsening, so it can be because of that. So
ma'am, I
what
have
we
one
need to
more
do
doubt
is
here.
that, yes, tell me.
This hemoglobin, she's having 9.8. So do I
Mhm.
need to say that we'll be correcting this hemoglobin levels with iron tablets, or should I talk about blood transfusion in this
Now,
patient?
now her hemoglobin you have to firstly repeat.
Yeah.
Yeah,
Yes.
somebody who's breathless and
Mm.
this thing. See, and to honestly tell you, Aisha,
Mm.
whether she will receive blood transfusion or not is not even your decision.
Yes, ma'am.
Is it? Will you manage this patient at your
No.
level alone by
No.
yourself? No. So it's not your hardcore job to tell her that I
Mm.
will put you on this particular drug or this beta blocker or that beta blocker or
Mm.
this diuretic. You don't have to because
Oh.
it's an SPT. Yeah,
Mm.
you're being tested on your ability to be able to tell a differential diagnosis
Okay.
and to be able to tell basic evaluation, then to summon the consultant under emergency and formulate that MDT, and then she will be shifted to ICU immediately, admitted immediately, all these things. When she talks about, no, I don't want to be separated from babies, you just have to
Mm.
reassure her that currently this can be, all these things we are looking at are quite serious. It
Mm.
didn't come across
Okay.
as to, yeah, so you
Okay.
understand what the thing is. And the patient may be breathless, but there is all postnatal anxiety and
Mm.
related issues with her. Firstly, she was not happy that she was away from the babies, as she mentioned to
Mm.
you, that she had to be away from the babies, and that was not very pleasant for her, and all these things. So, moment you do that, I tell you that this is the evaluation that you've asked for, and we have done
Mm.
these things again. We are looking at deterioration. So we have LV ejection fraction, which has dipped even more.
Mm.
Okay, that it looks like JVP is raised, tachycardia is there, crepitations are there, O2 sets have dropped,
Yes,
which
ma'am.
all is pointing towards possible worsening. Reasons you had not completely asked in history. For instance, apart from these medicines, are you on anything? Are you on blood thinners? Okay. Are you breastfeeding? These
Yes.
are essential questions. Yeah.
Okay,
So
ma'am.
then your management plan has to include, just for the purpose of the dog, admitting and all these things, and of course MDT, but basics you need to tell her. You need to stop breastfeeding. Hmm? You
Okay, ma'am.
need to put on blood thinners. You need to start bromocriptine if that's not. That is in line of management, and will be started on heart medications and things to sort of improve your urine output. Medications will be put injectable. Now you can think of giving injectable diuretic immediately for an urgent situation, right? You want to take care of the
Mm.
pulmonary edema. So basic things that you need in an emergency in this situation, you can talk about. Long term, you don't necessarily have to to tell into so much detail that this is how it is managed. But now again, why did you speak to me about future pregnancy? I don't want kids in the future. I didn't want it at all.
Okay.
That was not one of my questions. It was not being marked for you. You don't need to go there. So
Mm.
unless you had asked me that particular thing, have you any thoughts about future pregnancy? I would have said no. I don't want to know about that. And I
Okay, ma'am.
cut you off on that. Don't go with assumptions. Is the final message. Okay, we will go
Okay.
to the detailed feedback in a bit, but the gist of the second station is a relatively stable patient has come to you with almost similar sort of thing, similar sort of a picture at the time when she was admitted. But yes, Dr. Sandhya, what do you notice when you evaluated her, or you told her that we'll check pulse, blood pressure, and all these things, and because you come with breathlessness,
She's
I'll do an
stable.
echo. What did you see?
Yeah, her condition is stable. Her pulse is 90 and she's quite stable.
What about the echo? Yeah.
Yeah,
So what was it?
50%.
So it improved, no? Aren't you happy about
Yes,
that? Yeah. So the
yes.
thing is that yes, mild cardiomegaly will probably persist on the chest X-ray for some time. Echocardiography is showing that over a period of 5 weeks, she has improved. She has improved. She's not worsened. Uh, she is also not that bad in terms of saturation is not bad at all. She's very stable. Even if she's saying that when you asked her, she said that I'm just a little uncomfortable today, so I thought I'll come. But my agenda for coming in the station, the role player's agenda for coming is to ask you about my future pregnancy, which I was proceeding to. All right, and to formulate this management plan in terms of how you should do take care of her as far as the next pregnancy is concerned. Okay, so that's the agenda in a nutshell for you in both the stations. Okay, all right. Now, what do you feel about how you guys started the station? Let's go into detailed feedbacks of each of the station now. What do you think about how you started the stations? Especially Dr. Ayesha. How do you think you could have done? Yes, Dr. Ayesha? Dr. Ayesha? Are you there? I don't know if she's left. Sandhya, yes, is there anything you would like to have done differently since I'm asking you this question?
Few of the important questions get missed. Like I should ask that whether this type of symptoms she had previously or not.
No,
And
no, I'm not asking you information gathering. I'm asking you how you begin a station. The first thing that we teach is how are you going to make an impression as a good ST5, as a candidate who is remarkable, who is different. You can make out that impression as an examiner right when that first line is spoken by the candidate, any candidate who enters. When a scenario is given to you where there is somebody who is mentioned to be in any sort of distress, okay, whether it's the
how are you
scenario says
feeling now?
that person is ah,
How are
why
you
was
feeling
that not
now?
asked? Why was that not asked? Regardless what happens eventually in the station. Okay, rest of your history you may be but by hearted it and gone and spoken it like a parrot. But empathetic, an empathetic doctor, okay, only will be the person who realizes that this person is in some sort of a distress. I need to ask about that first, even before you do your confirmation of name and this and that. Okay, even that you can do later. But you need to go and say that I'm Dr. Sandhya, I'm one of the doctors here today. I understand that you are having some sort of distress, having breathing difficulty. Can I do something for you? That's the first thing. In both the scenarios, I'm not distinguishing between. Now, the second patient tells you, no, I'm fine. That's okay. Let's just go on. You'll know from the body language. You'll know from the way she's talking. She's not acting very, fussy about giving you any history. So she'll be fine. But this is how you need to begin under any though again, no presumptions about how the patient will behave with you. Begin
Yes.
with asking about patient well-being. Well-being goes a long way into making a good impression about what caliber of a candidate you are. Okay. Next, you are going to ask me, okay, fine, I understand you're in this situation. So can you tell me more? Open question. All right. So again, for the name, this and that, you guys are in age and all. Why are there 3 or 4 questions being wasted on that particular thing. You can just say that, may I, or what would you like to be addressed as or called as? You can call me this, done. May I confirm your age? Done. Okay, first, may I ask your name and age? Can I call you this? Is not required. So it's a complete waste of time. Firstly, it gains you no marks at all. So you can just enter, introduce yourself, ask her well-being, say that, okay, fine, okay. Can I get something for you? She'll say, no, I'm feeling much better. Please continue. May I, what would you like to be addressed as? So and so. May I ask your age? Done. Then you move to the open question. Is, can you tell me what's happening or what problem you're facing right now? Then she'll say that actually she'll tell you her story basically. Her story, which involved her delivery related, and she was told that there was some bleeding, then she was given blood, blah blah. She'll tell you her thing, and she'll stop at some point of time. You need to ask certain things in terms of yes, because she didn't say that I've been diagnosed with peripartum cardiomyopathy, but the investigations look like it, right? They look like peripartum cardiomyopathy. You don't. It's a diagnosis of exclusion. Everybody agrees about that. Yeah.
Yes.
Yes, ma'am.
Yeah. Okay. So it's a diagnosis of exclusion. What are your investigations telling you at this point of time? It could be cardiomyopathy, PPCM, or it could be some other cardiomyopathy as well, right? Yes, natriuretic peptides and anti-proBNP, these are very high, that which is indicating that there is some condition of heart failure, and ejection fraction is low, of course. So this is alarming for you, but then this was at the time, and then she was better and she was discharged. Right. So you're basically looking into that direction in terms of your history as well. So you'll ask for, have you had this sort of breathing difficulty or other complaints previously as well? Okay. The first station's history will be slightly different in terms of you would be asking about since when are you so breathless? Since are you having chest pain? All right. Are you having cough? What are the main things that you're looking at here? Cough, any expectoration. If she is having pinkish frothy sputum, you're very alarmed, aren't you? Hmm? So you're looking at the scenario as to how emergent is this situation. Okay, there. Okay, so and other things like precordial pain, swelling of the legs, and left upper quadrant pain. These will be common things that you're looking at a patient in a heart failure. Yes, basic MBBS level history. Agreed? Aisha, Sandhya, everybody else,
Yes, ma'am.
people are listening.
Yes, ma'am.
Shaista, Sazia, Shima, Susan. Yeah. All right. So once you do that, you go to the antenatal, asking about whatever she hasn't filled up the gaps for you in terms of her pregnancy, how it was, whether there was any problems at the time, yeah, any risk factors. PET, you guys, both of you asked me, that's fine. Check her background understanding, which was again done by both of you. I really appreciate that you asked me what were you told about the condition when you were in the hospital. Obviously, there is some amount of debriefing which has happened. You can sort of like assume that, but don't be sure of that. Always ask the patient. Ask the patient what does she know about her situation. Hmm? Then we also asked about in the second patient, other things become more and more relevant. Routine postnatal questions become more relevant. Like, are you having any other complaints like bowel bladder problems, any ongoing bleeding, fever, discharge? All right, all these things will be there. Yeah, and then again, I know you have gone through a lot. So that empathy has been there. I'm so sorry to hear what you have gone through. I know it must have been difficult. Okay, how are you coping with it? Hmm? If you want, I can arrange for some help. Now, this thing will be with the stable patient, of course, because in the first scenario, you're looking at an emergency. Yeah. Okay, guys. Wanted to
Yes, ma'am.
understand the difference between these two stations as a whole. That's why I'm taking the two feedbacks parallel together. Okay, But I don't want you to get confused between feedback of the first one and the second one, and then sort of like confuse the two things. Yeah. So listen very carefully.
Ma'am, I have
Now,
one question, ma'am.
yes, Aisha.
Ma'am, when the patient says that she's more worried about the babies, so this can happen in any emergency scenario. When the patient says that she cannot leave her kids or she's worried because in previous exam I had similar condition when the patient said like
Headache.
this.
Headache.
So, ma'am, should we say
Okay.
that okay, we can offer you some support services? Do they have any facilities like support services, or we just say no, presently it is more important about your safety?
You have to tell her this is important about your safety, and we can arrange for the babies to be with you in the, near you in the hospital as well. And
Okay.
there is social services available who can even look after the babies. But it is important that what is essential there is you have to understand why the patient is not agreeing. You have to understand the motivation
Hmm.
behind the question.
Hmm.
So she is probably not understanding how serious this is. Yeah.
Okay. Yes,
So
ma'am.
oftentimes, even when we are doing labor ward negotiation, this is the same problem. Role player keeps saying, no, no, I can deliver at home. I want to deliver at home. I want to. And you keep on saying the same thing. And you don't tell her that she can die or she can have a PPH
Okay.
and life-threatening baby can die, and you don't say these things to her, she's going to keep saying the same. So this is that
Hmm.
sort of a negotiation power which you need to execute at that point of time, saying that this is like really serious and these are the things, these are the consequences. It can really get worse, and we are looking at your safety, and because it's so serious, that's why we are advising you. So
Okay.
usually the answers are not that complicated. It's just your
Hmm.
viewpoint of looking at that particular question is very skewed. You're looking at it in only one direction. You should try to think what they are expecting. Hmm?
Okay.
So,
Thank you,
in
ma'am.
fact, in fact, that question itself is like a prompter. It means you're not telling something which is vital information.
Hmm.
It's like that.
Thank you.
Hello,
So, yes.
ma'am. I have a question that in case of online exam, how can we arrange oxygen for the patient? We have to tell like
What
this that would I call my sister to give you oxygen in case of online exam?
you can do that. This particular, the first scenario was probably not designed for you for online. The second one is, okay. And yeah, still, if it comes like this, there is no harm in doing the right thing and providing the right approach for this. If you need to give oxygen, you need to say that I will arrange for oxygen for you. You don't have to name also the person who is there. Don't complicate matters. Yeah, who will provide the oxygen? I will have the oxygen arranged
Oh,
for you. Obviously, if someone is in A&E, that question should not be online. But we have seen questions wherein patient has come in A&E and you're doing it online, right? You're not doing just routine consultations. So what you need to do essentially, you need to do the same things in both exams, including you're talking about, I would like to do this particular examination, and then it's provided to you. So it can happen in both cases. Okay,
okay.
it's not
Thank
not not a big deal. It's really not. Then we move to the next bit, which is how does she manage the babies? Any additional help, support, everything that both of you asked. Okay. Um, ethnicity is something that may come up in the second station. If I were to ask you, yeah, doctor, why did this happen to me? Okay. So, why does this happen, or why does this heart failure occur at all? So, how will you ask for ethnicity? It's a very interesting question. Let us hear from someone in the audience. How will you ask for ethnicity? Dr. Aarti. No? Aparna, Annam, Bismil? No?
Yes. Yeah, Doctor, can
Sandhya,
I,
yes.
yeah,
Hmm.
I can
Yes.
tell
Tell,
where
tell.
are you originally from?
Yes. Okay. Okay. Didn't sound offensive. Very good. Some. people may take an offense against this. If you want to be completely safe from that, you have to, because there may be some judgmental overtones into asking ethnicity sometimes. So what you need to just signpost before that question. If you feel anything is awkward, signpost as to why you're asking that question and then ask the question. Just like you do in STI history, similarly, you say some of the questions I ask may be able to help me explain your situation better. Where are you originally from? Or what ethnic group do you belong to? All right. So you know that in Afro-Caribbean, especially, the PPCM prognosis can be bad and they are more predisposed to it. So if they are asking you, tell me the risk factors I had, okay, in other terms, they will ask you, why did I have this doctor? So basically they are asking you the simple question, tell the risk factors. So if this were a structured discussion, this question would have been, risk factors were there in this patient or not? So the same way, you are eliciting the risk factors in history now, yeah? So you'll ask about that. Only if potentially that question can come up. Now, and currently, what medicines are you on? Are you taking regularly? Did you visit any time in the postnatal period during this particular period of time? Breastfeeding, Aisha, very, very important question. Okay.
Yes, ma'am.
Aisha is with us. Yeah. Okay. So why is that so important? Again, because
Because it is related to prolactin levels, postpartum cardiomyopathy.
Yes.
And patient is also not very stable to breastfeed at this present moment.
It would be, given the worsening of the situation. So firstly, she was evaluated. She was probably, you know, at 35% or 45%. She was okay. Then she is now, she was discharged with certain medications, and because they didn't deem it necessary, probably not started on blood thinners and not started on bromocriptine, not started on breastfeeding cessation. She was allowed to go home. But now she's come back with a situation which is showing you that she's worsening. Under the circumstance, your advice for her will be to stop all these things, and yeah, so your management plan will differ. So these questions are essential. Pre-existing medical conditions, yes, Dr. Sandhya pointed that out, is very good in terms of did you have antecedently any pain or any breathlessness ever before? Because you didn't have PPCM handed out to you. Instead, if I had a station wherein I told you she was diagnosed with peripartum cardiomyopathy, and you have to ask a history, then some of these questions can just go skipped. Why? Because you have been told that this is the diagnosis. So you are probably only going to look for what was there during the pregnancy, like which were the risk factors, which were PT, for instance, and other things like IVF is there that you've been provided. Yeah, her twin pregnancies that you've been provided, and PET wasn't there. So ethnicity was one of the factors which was there, but that again, that question I didn't really ask Dr. Sandhya, so it was okay. Then coming to your surgeries, allergies, smoking, alcohol, drug addictions, blood groups, BMI, and you've already asked mental health in a very specific and a different way here. So you've asked about how she is coping with this situation. This must be difficult for you. How are you coping with this at present? And if you really want, we can put you in touch with a counselor. All right, counselor. So then, what else? Essentially, which again you got confused about, Dr. Aisha. The same thing which I have already told before. Does she want kids in the future? What about future pregnancy? What are the expectations? Does that have to be discussed? And has she begun sexual activity? And what, if at all, contraception is she on? Okay.
Okay, ma'am.
Yeah. So once you ask these things to her, you are going to move to tell her in the first scenario or the second one. In fact, you are going to tell her this similar thing. I would like to now examine you, check for the following things: pulse, blood pressure, your chest, all right, and your oxygen sats and ECG, chest X-ray, ABG, all of this wherever relevant. Okay, I'm just telling you as a ballpark figure. You will tell about echo, repeat echo, and in the first scenario you would do a more intensive evaluation. Okay, agenda there is to tell her about the potential DDs that you're thinking at that point of time. So what is the examiner marking you as? So as you're saying that I think it could be this or this or this, and that's why I need the following investigations, including your echo, ECG, chest X-ray, ABG, right? Some blood evaluations looking for inflammatory markers, and your hemoglobin, very essentially, because breathlessness compounded by your anemia as well, right? In this
Yes.
particular situation. So you have to, you're basically doing your job as an ST5 of evaluating the basics and then handing over, starting it off over there and then going on to more intensive. So at that point of time, you are provided with the investigations which we have done and we have asked for. Okay.
Yes, ma'am.
So now again I'm telling you, applied clinical knowledge and patient safety were purely reliant on that DD, your ability to tell the DD, and your ability to evaluate or to tell the correct investigations which you needed to do under the circumstance. Once you are marked for that, then you're given the investigations, and then based on that, you will tell, okay, this looks like it's worsening cardiomyopathy itself. All right, and then you tell the highlights of the management. In this scenario, future pregnancy was not discussed at all. Okay, which was a one chunk of information you could have skipped.
Yes, ma'am.
So, what will you tell now? Now let's assume that you are at that point where you have been given the second set of investigations. Now, what will you tell me?
I'll say that after going through your investigations, I see that in the first scenario, ma'am, or this one, the present
First,
page.
first one, first one.
So in
I'll
her
show you.
previous,
I'll show you. One second, huh? So, yeah. Okay, this is one.
so I'll tell the patient that she's having increased pulse rate in this. It could be because of the pain, and her ECG also shows that there are some changes in the heart rhythm. Probably it could be a possibility that condition called as myocardial infarction, but needs more evaluation. We need to do some more test like troponin I, and her saturations are towards the lower side. And there is also possibility that there could be a blood clot formation. So we will be checking her blood parameters for that, coagulation profile. And here the white blood cells, it says that there is a possibility of infection as well. So we'll send some more urine test and blood cultures. And the hemoglobin is also towards the lower side. So we will be discussing with the cardiologist about whether there is a need for blood transfusion as well. And
So you're taking everything one by one, I feel that, and then getting confused. See, I want you to tell me all this differential diagnosis before the evaluation is done, right? But gross picture of this evaluation is just cardiomyopathy also. In PPCM as well, you can have WBC count raised, hemoglobins drop. Yeah, and the same picture. All right. Basically, this is the evaluation of a failure. This is heart failure.
yes, ma'am.
This doesn't look typically like an MI because you can get sinus tachycardia and ST, non-specific ST changes in PPCM itself. And you can, basically what is happening here is that the LV ejection fraction is basically reduced now, reduced.
Yes.
And there are basal creps. Everything you have to put together and make a diagnosis. Now you can't like separately tell her that this one looks like infection and that one looks like this, that. It's fine. You can think of infection, but Here in this circumstance, you need to tell her that this seems to be that the heart condition which you had, which is called as PPCM, wherein the heart muscles are not functioning very effectively, they are not pumping blood adequately. That's why a person gets breathless. Now repeat evaluation is showing that there is possible worsening of that thing. I could have provided you with a very different set of investigations. I could have told you that I have done the CTPA and that's showing a clot here. The entire line of management would change on
Yes,
that
yes.
basis. So it all depends. Go with the flow of the station and do it as it is, like, right? So just evaluate each thing as it comes to you, is what is in front of me right now and what am I to say now. So if there is worsening, you need to tell her that unfortunately, I'm so sorry that this is there. So what I need to do is, this is an emergency situation. You have to utter this word. Okay, if you don't say it, examiner doesn't, take it for granted that, this candidate knows that this is emergency. No, you say it to the
Okay,
patient.
ma'am.
All right,
Okay.
you utter. In both, in the second one, you may not tell her because you have to be more reassuring sort of a thing. Based on her picture, she's showing improvement. In the first one, you have to tell her, yes, this looks like an emergent situation. You're also quite breathless, and I'm very concerned about that. So I'll take some immediate steps right now. It seems to me now you can make a diagnosis. What is your diagnosis? Worsening heart failure.
Worsening of heart failure.
Heart
Yes, ma'am.
failure. Heart failure. I'm saying heart failure. I'm not saying PPCM, right?
Okay.
Why?
Yes, yes.
Is because it can be any kind of heart failure.
Other,
Yeah.
yes, yes.
It can be the viral heart failure also. Can. I'm not saying. I don't know. But
Yes.
I'm telling you what I know as an ST5 right now is that heart failure is worsening. And I will put you, I've started oxygen. We'll try to, check your saturations throughout. We'll put you, it's better you remain in an upright position. I'll give you an injection. Yeah. You talk about diuretic right now. First thing, what we will give a patient with
Diuretic.
pulmonary edema, diuretic. I'll give you furosemide. That you don't, it's a no-brainer. You don't have to wait for your senior to come before the patient gets more breathless and dies. So you can do this much. And you have to tell that immediately I will admit you, shift you to an ICU. Tell the reason first. So, unfortunately, I'm sorry to have to say this. Is there somebody with you? I can ask someone to be with you here to support you through this process. But unfortunately, in initial investigation shows that the heart failure might be worsening, and this means that fluid can back up in the lungs, and that's why you're getting breathless. If this condition worsens, it can get very serious. And I'm not trying to scare you, but sometimes we may even lose patients with this condition. Okay, so we need to act now. We need to act critically. This is what we are going to do, and we'll start off all this initial management. I will call my senior hematologist, cardiologist, specialist nurse. We'll put you in ICU. We'll put you monitoring on Meows chart. All right, and put more injectables to kind of put you in a dehydrated state, or to increase your urine output so that there is less load on the heart. Okay, and start you on heart medications enough. So whether you know you're an expert in cardiomyopathy or not is not really necessary.
Yes, ma'am.
Another thing which you should have advised at that point of time, like when you were doing the evaluation with the increased breathlessness, was the cardiac MRI, because that is one of the uh, evaluation which looks at an intracardiac thrombus
Okay, ma'am.
and show it better than an echo for picking it up. So you can talk about that. All right. So now, after this, all this is done. You tell her that I will start you on blood thinners. See how many points are there in this now. Blood thinners are to be started her on because she's not receiving anything. Tell her about that she will not be able to breastfeed. It's not advisable. Start her on bromocriptine to see if this is becoming better or not. Tell her about contraception, which is safe and ongoing, right? And you to talk to her about, we will arrange for everybody to come emergent, and at a later point of time we will also support you through this process. It must be very distressing, and we will make sure that there is arrangement as soon as you are fit to see your babies. They will be in and around. Okay, and we can
Okay.
arrange for you to see the or help for you to take care of the babies as well, if that is a concern.
Hmm.
Then there is another thing about duty of candor here. Patient safety. What is it? Anybody? Anybody? Guys, come on. It's something which has happened in a station in the past. Okay.
Incident reporting. Previous PPH.
PPH
She
fine.
had a
Okay.
previous
Yes.
PPH, so
She
incident
had. Will
report.
you? This is an emergency situation.
Yes.
Your station, I understand, like Dr. Sandhya's station, you can still say that incident report has been done probably at the time of your delivery, and that investigation will be conveyed to you in a transparent manner. That's a different thing. But what is not being done here, which should there are two kinds of mismanagements which can happen. There is act of commission and act of omission. Something has been omitted here. She should have been on. Yeah. Her rejection fraction was 35%. If it was more, she shouldn't have been, but may not have been. But since it's 35% or less, she should have been considered for starting low molecular weight parents, and that continues for about 6 to 8 months after the delivery as well. She should have been on it, and you need to mention that. That's duty of candor. Okay. Retics thing you may or may not like. It's far-fetched. I would say first one I would not mark retics, and second one I would. I would. Okay. But then again, you won't say I will do retics now. Of course not. It is done already, and it is will be conveyed to her. That's the way it goes. All right. So that's the management plan in the first scenario. Now let's come to Dr. Sandhya. Sandhya actually did, because you were you familiar with the station, Dr. Sandhya?
I have done
Hello.
first time this is just
Great.
actually ma'am,
In that case,
first time
I'm very
actually.
happy. I'm very happy. Okay, but you were on the right track. You were addressing, you took one question by the role player, and you were trying to address that. So I'm really glad that somewhere the approach at least was correct. Yeah. So in this circumstance, I asked you, yeah, but I want to plan my pregnancy in the future. I want to conceive soon. What is my thing? What do you need to tell her at that point of time? You can't say go ahead. Ejection fraction is yet 50%. Okay, you can't tell her no, it's contraindicated in this. You need to give her applied clinical knowledge and patient safety points in terms of future pregnancy planning. So the second station's patient safety and ACK points highly reliant on how safe a management plan are you making for future pregnancy. Okay, history all will, as I've told you, the template will just be varying very little from each other. But yes, of course, what contraception are you on? What are your future pregnancy wishes? All those are very essential questions when you're looking at this. Okay. So you need to tell her right now, things seem to be settling. You seem to be improving. We will, of course, evaluate you. Okay. And before planning a pregnancy, of course, you need a pre-pregnancy evaluation. Yeah. Pre-pregnancy workup as well. What are the points in that? You need to, sorry. So you need to tell her that in this condition, usually if what we are suspecting most probably is something called as peripartum cardiomyopathy, wherein the heart muscle has weakened, it is not functioning or pumping as well as it should be, and that causes the breathlessness. But in your situation, it seems to be improving, and you can continue to be on the breastfeeding regimen that you are on. And secondly, I think I had also put that no, in the second patient I have not. put that blood thinners over there. But yes, in my script, if you had asked me, I would have told that I am on blood thinners. You need to tell her to be on the same. Yeah, be on the same, be on the continuation of all of this. And after this, you need to discuss about subsequent pregnancy, which is if the heart function improves, okay, then you will be advised, you can go ahead, okay, with another pregnancy, but with due risk because there is a chance of recurrence, and you need to give details about what the recurrence rate is. That is part of ACK, and you need to give her warnings about what all she needs to do before planning the next pregnancy. Points in that will include that there is a 50% chance for further deterioration if there is persistent heart failure or your ventricles, that is the left chamber of the heart, is not pumping as well as it should be, then there is a 1 in 2 chance that the function can worsen. All right, and the chance of death, I'm not trying to scare you, but the chance of dying in the next pregnancy may be as high as 1 in 5, 20%. However, if you embark on the pregnancy while your heart has fully recovered, okay, then it will be better. And still, however, 1 in 5 can have this condition happening again. All right. So
Yes.
if the ejection fraction is less than 25, of course, there's no question of thinking about a pregnancy. If that comes, you tell her that because of this situation, it's contraindicated. They should not be counseled to become pregnant again. Okay, got me so far? Everybody clear on these management issues there? Any questions? I'm just going on. I just need to, any questions? Let me take names. Prem Lata, Priya, Rajni, Dr. Rajni, any questions?
No, thank you.
All right, great. So,
No, ma'am.
hi, thanks. So, timing of the delivery is guided by obstetric indication. So, you need to tell her a management plan for future pregnancy because that's what she is asking. When she's asking, that means the examiner key is having this particular points for you to be marked on. Very simple. So, answer her questions and you're through. So, she asked you about my future pregnancy. Can you tell me more about it? So she's, you have to just go through that one by one and telling her the timing of the delivery will usually be the pregnancy itself first before we are planning. You have to say that multidisciplinary team, which you spoke about, cardiologist, obstetric physician, obstetrician, with an interest in maternal medicine, okay, then anesthetist, okay, baby doctor, all these other and allied specialties will be there managing. Then we will review the medications that you are on at that point of time and make a plan to stop the unsafe medications that you might be on, right? So if she's in a non-pregnant state, she might be on ACE inhibitors, ARBs, yeah. And then again, you will have to review all this in a pre-pregnancy counseling, which she needs to take. She'll have to be booked early, consultant-led care. Continue the treatment with beta blockers, followed up closely with BNP levels. We'll have to monitor you with the markers for the heart disease. Very simple. Keep it very, very simple. We'll have to monitor you. Of course, as long as she's on beta blockers, what else do you have to monitor? Baby. Growth of the baby. Okay?
Yes.
Great. So there is also a chart, if you've seen in the log, which says when all to do the echo. So it's run preconceptionally, end of first trimester, second trimester, and a month before delivery, after delivery. You don't have to just tell her the full timeline of it. If you have time, you can do that. But you have to say that we will serially monitor throughout the course of your pregnancy, and before the pregnancy even, your heart's condition, and see that it's pumping adequately before you are advised to carry on with getting pregnant again. Yeah, and then you talk about the delivery things. So usually the delivery timings are guided by OBS indications, and So we will try to, unless there are other problems which develop, the pregnancy will go till 9 months, and uh, then the delivery also can be, if all remains stable, heart remains stable through that pregnancy, delivery also can be normal delivery, but it will be here. And of course, we will monitor you because we are looking for a recurrence at that point of time. Hmm? And another most important patient safety point is do not conceive before that. Do not conceive till we give you a green signal to go ahead and be on very safe and effective contraception. Okay?
Okay.
Hmm?
Yes, ma'am.
Then later on, last station, second station, you will give her PIL. How you wind up a typical OPD consultation, same way. Give her PIL, any support that she needs, right? Don't fix another postnatal this thing appointment for her. The same patient, it could even be mentioned that she's come to visit the consultant with a postnatal visit, something like that. In that case, your station beginning will be slightly different, right? So you know how to tackle that. The consultant visit is there. You have to mention that bit first. So I haven't really written that. So it's okay. But be careful when, maternal medicine people are coming for follow-up, serious cases are coming for follow-up. Usually the consultant referral may be there, and you have to be very, vigilant about that. Okay. All right. Any questions? Yes, and a couple of things I wrote down, which I was alarmed by Dr. Aisha.
Yes, ma'am.
You said congratulations to me.
Because she said she has twin babies. So
Don't do that. Look at the situation. Look at an emergency. She's in bad condition. Okay?
yes,
Don't prematurely. It will harm your communication skill. Yeah, so
okay.
don't be very careful. It's better not to say when you are unsure whether she's in, she's not happy. So don't. Okay. Secondly, Dr. Sandhya also, in another thing which we commonly tell everybody, apart from a good beginning, is don't club questions. Do you smoke or drink or this? No. Okay.
Okay.
Yeah, so never
Yes, ma'am.
club questions. That's just a basic principle of history taking. You'll find it in any part 3 book as a basic thing, advice in history taking. History taking is never club questions. And yeah, so I think that's about it from my end today.
Ma'am, in emergency also we say while ending up the station we say that we'll give you some patient information leaflets.
And no, not really. You can say when we are, at about when you are better, maybe we will think about having a counseling session for you or debrief you in detail about this
Okay.
and give you written. But that's something. In this scenario, where would you have the time even to do that?
Okay.
Actually, there's a lot of things that you're handling there. You're first going with the DD. That's essential. So you are telling,
Okay.
we are evaluating you. What are we evaluating? For your ability to understand emergency, to make a DD. Post-op also cases. Not expected to tell that this is, no, your ureter is injured. How do you know ureter is injured? You don't know. You've
Yes,
been
ma'am.
given some scenario. It could be sepsis. For all you know, a lot of things clinically look the same till you do investigation, right? So don't jump, don't be in that state of mind that I need to diagnose this. Oh my God, if I don't tell the correct diagnosis, I'm going to fail the station. No, that's not how it works. You tell a DD and you say, okay, this is what. So think of it. See, all of you are like good doctors, practicing doctors. You know, if this situation comes to you in real life, you would do the right things. So in stations, why do it differently?
Okay.
All righty, time for questions. Any questions? Yep. Okay, righty. Fine. Okay.